This PowerPoint covers the physiology of pain and temperature sensation, sleep, brain waves, and seizures. Before we cover the physiology of pain, I want to go over the definition of some terms associated with pain. The word pain itself is an unpleasant stimulus associated with impending or actual tissue damage. Nociception is detection of pain sensation. Allodynia is a non-painful stimulus that evokes pain sensation. Hyperalgesia is extreme sensitivity to pain stimuli. It can be idiopathic, someone can have a low pain tolerance, or it can be from memory because of hyperstimulation, which led to long-term potentiation of the receiving neurons, which led to memory pain and or just increased sensitivity to a stimulus. Causalgia is persistent, severe, burning sensation following partial injury of a peripheral nerve, very similar to like a burner with neuralgia. Analgesia is the state in which a painful stimulus is still perceived but no longer painful. That means the brain is still understanding there's a pain stimulus coming in, but because of natural opiates or maybe pharmaceutical opiates, those pain receptors are not fully transmitting the sensation. Have you ever stubbed your toe and for the first 2 or 3 seconds it hurts so bad that you can't even say a cuss word? You can't even breathe. And then after a few seconds, it starts to throb and then burn. Well, this is the example of the two types of pain. There's fast pain and slow pain. Both types of pain travel in the lateral spinothalamic tract, and they account for the double sensation of pain. First, fast pain sensation, and then it's followed by slow pain sensation. And I already gave the example of stubbing your toe. Fast pain begins 0.1 seconds after the stimulus. Before you can even say, ouch, you're experiencing the fast pain. I use the example of the stubbing your toe, and here I have an x-ray of a person with a fractured ulna. You can imagine that as soon as it was fractured, because of it involving the periosteum, and you can see the way it's fractured, it also involved cutaneous tissue. That person felt immediate fast pain. Some of the adjectives to describe it, it could be sharp, pricking, acute, electric, stabbing. There's a lot of variety of types of adjectives that could be used, but it's all very, very sudden and strong pain. This type of pain can be precisely located, and that's because fast pain fibers will synapse in the thalamus at the same place that the fasciculus gracilis fibers synapse that can carry sensation, where you can have pinpoint accuracy of where the sensation is coming from. Fast pain is mostly cutaneous or superficial, and it's not typically felt in deeper tissues. Slow pain begins about 1 second after stimulus. It is considered slow because it can be chronic, and it has different types of sensations, and adjectives to describe it would be like burning, aching, throbbing. This type of pain can make you nauseous. It can keep you awake at night. It detects tissue destruction. So when you initially have your fast pain, your brain knows part of you's been injured, but it hasn't assessed really what kind of damage is happening. Well, when you actually are presenting with some tissue destruction, that's being perceived by slow pain fibers. This can occur everywhere, in the skin, in superficial tissue, and deeper tissues and deep in the organs. In fact, visceral tissue only carries its pain sensation in slow pain fibers. This can lead to prolonged, unbearable suffering, chronic suffering. Pain receptors are also nociceptors. They are found on all free nerve endings. They're widespread throughout the skin, the periosteum, arterial walls, joint surfaces, the falx cerebri, and the tentorium of the cranial vault. They're kind of sparse, though, in deep tissue in the viscera. The viscera does have them, but not as much as it does in the other areas I mentioned, and that's another reason why viscera damage is really quite extensive before you would even feel visceral pain. That is why visceral pain signals can summate, and when they do summate, when you have a lot of tissue damage in the viscera, they summate and you feel the pain. There's 3 types of stimuli: mechanical, thermal, and chemical. Chemical stimuli are chemicals that excite pain receptors. There's several of them. I've got a short list here: bradykinin, serotonin, histamine, potassium, acetylcholine, proteolytic enzymes, lactic acid. Those can all elicit pain. Now, bradykinin, serotonin, and histamine are part of like an immune system response. Potassium and proteolytic enzymes and lactic acids are substances that are within a cell, and when there's tissue damage and that cell has been breached or torn open, this shows a thorn as an example, and so the cell contents is released into the surrounding interstitial fluid. And so those substances like the potassium and proteolytic enzymes and lactic acid, well, that aren't supposed to be in there, will elicit pain. Acetylcholine plays a role also in transmitting pain signals. Chemical stimuli continue. Prostaglandins and substance P lead to increased sensitivity of free nerve endings. In fact, we'll learn a little later on how substance P is actually responsible for the long-term potentiation of chronic pain. Bradykinin is most responsible for causing pain due to tissue damage. It is part of the chemotaxis that's released when tissue is damaged. Potassium and proteolytic enzymes, they're released with tissue damage from the damaged cells. Potassium from intracellular fluid. And potassium directly attacks nerve endings. Proteolytic enzymes from ruptured lysosomes. We saw on the other page, talked about lactic acid. We'll get to that in a little bit. The intensity of pain felt correlates with the amount of interstitial potassium and or proteolytic enzymes present. That's because that's relative to the amount of tissue cells that are damaged. Pain receptors adapting. It rarely happens. Pain receptors typically do not adapt to a sensation. More often, they will develop hyperalgesia, which is increased sensitivity pain. They are subject to long-term potentiation, which could lead to pain memory. And the example of that is phantom limb pain, where someone has lost a limb, but they still feel the pain at the end of their stump, and often need to have some injections to actually deaden the nerve endings to get some relief from that type of sensation. Intensity of pain is proportional to the rate and type of tissue damage. Types of tissue damage that elicit pain are inflammation or infection, contusions, lacerations, abrasions, and ischemia. Tissue ischemia. Blocked blood flow will lead to tissue damage, and then pain-stimulating chemicals will be released into the surrounding tissue. These chemicals then excite nociceptors, which cause pain. Another thing that happens with ischemia is that there's blocked blood flow, and if you have blocked blood flow, you're going to have a decrease in oxygen. If you have less oxygen in the area, you're going to increase glycolysis, which is anaerobic. If you have increase in glycolysis, you're going to have increased lactic acid. Increased lactic acid is going to excite chemical nociceptors and lead to pain. The greater the rate of metabolism of a tissue, the more rapidly the pain appears. I have an example here showing a heart. This cardiac tissue is operates on a very high metabolic rate. because that heart never takes a break. Well, the chemicals that are released from the tissues that have died as a result of the ischemia and because of the increased lactic acid will cause very quick pain. It'll cause both pain over the chest and radiating down the arm because of the ischemia. Muscle spasms are a common cause of pain. They elicit two types of receptors. The direct effect is going to stimulate mechanoreceptors, where the contraction is actually pressing on mechanoreceptors that are in the muscle and the skin, like the Pachycenaean corpuscles or the Ruffinian corpuscles, and they're sending pain signals. The indirect effect is as a result of compression of the blood vessels. Those contracted muscles are also going to put pressure on the arterial blood flow going through those muscles. Well, you'll have a point of ischemia. So beyond or distal to that ischemia, that tissue is going to have reduced blood flow, so they'll have reduced oxygen levels. If you have reduced oxygen levels, you're going to have increased lactic acid, and so you're going to have release of chemicals, and that's going to give an indirect effect of the pain signals. There's two pain pathways. One pathway is the neo-spinothalamic pathway, and the other is the paleo-spinothalamic pathway. Both pathways send first-order neurons to synapse in the dorsal horn. Then they send fibers to the opposite side of the cord through the anterior commissure. Both pathways travel in the spinothalamic tract, and both pathways secrete glutamate as the stimulatory neurotransmitter. The neo-spinothalamic pathways carries fast pain fibers. The fibers are specifically type A delta fibers, and they can transmit a signal within 6 to 30 milliseconds. They will transmit mechanical and acute thermal pain. These fast pain fibers are not actually transmitting chemical pain. They are able to locate or localize and pinpoint exactly where the pain is being elicited. So fast pain pathway review is the neo-spinothalamic pathway with type A delta fibers will secrete glutamate. First order neurons travel through the peripheral nerves to terminate in the dorsal horn, where they will synapse with second order neurons. The second order neurons will cross to the opposite side of the cord through the anterior commissure. Then axons will travel up the cord in the anterior lateral spinothalamic tract, and they'll terminate in the thalamus. They'll terminate specifically at the ventroposterior lateral nucleus, and that is the same nucleus that the fasciculus gracilis axons terminate. That's what enables the brain to precisely locate where the initial stimulus came from for the fast pain signal. Then from the thalamus, the third order neurons will travel up to the specific somatosensory cortex. The paleo-spinothalamic pathway carries slow pain fibers. They're unmyelinated type C fibers, and they'll transmit signals in 0.5 to 2 milliseconds. They transmit all the types of pain: mechanical, chronic thermal, and chemical pain. And this is chemicals that are released because of tissue damage. The location of pain is general because they synapse somewhere else in the thalamus, not at the ventroposterior lateral nucleus. They secrete glutamate as well as the neo-spinothalamic pathway, but they also secrete substance P. Glutamate is the fast-acting neurotransmitter, but substance P is the long-acting neurotransmitter, or it's actually a neuropeptide. Slow pain pathway course 1. It has two courses. The first course is the spinothalamic pathway 1 will send unmyelinated type C fibers that secrete glutamate and substance P. It's also sometimes referred to as the spinal reticular tract. Okay, first order neurons will synapse in the dorsal horn at either lamina 2 or lamina 3, which is known as the substantia gelatinosa. They'll synapse with second order neurons that transmit signals within the dorsal horn from lamina 2 or lamina 3 to lamina 5. So they haven't crossed over at this point. These will be very tiny, short second order neurons. Then within the same dorsal horn at lamina 5, those second order neurons will synapse with a third order neuron that will cross through the cord, actually cross through the anterior commissure, and then travel up the cord in the anterior lateral spinal thalamic tract. Most of these third order neurons will terminate in the brainstem, specifically the reticular formation in the medulla, pons, and mesencephalon. And these neurons also can affect sleep, because when we get down to talking about the sleep, we'll see how the reticular formation plays a role in sleep, and how if pain signals are constantly lighting it up, that's one of the reasons why it's hard to sleep if you experience chronic pain. Slow pain pathway course 2. The spinal thalamic pathway 2 will send unmyelinated type C fibers that secrete glutamate and substance P, and again, it's also known as spinal reticular tract. These first order neurons will terminate in the dorsal horn, just like all first order sensory neurons, terminates in the dorsal horn. But this one will terminate at lamina 5 the first time. And then at lamina 5, it will synapse with second order neurons that will cross through the cord through the anterior commissure. Then these axons will travel up the cord in the anterior lateral spinal thalamic tract and synapse in the brainstem. Some will synapse in this brainstem at the medulla, the pons, or the mesencephalon. Then third order neurons will relay signals to the thalamus, the hypothalamus, the cingulate gyrus, and the somatosensory cortex. And this pathway is responsible for the emotional aspect of pain and a visceral response to pain. So remember when I talked about how slow pain can cause nausea? This is the pathway. So chronic slow pain will disrupt your patient's sleep. It'll make them nauseous, and it's going to affect their emotions. It can also lead to depression just because of the actual physiology of pain signals. The perception of pain. Conscious pain is perceived mostly by lower brain centers like the brainstem, reticular formation. So the somatosensory cortex that receives the pain signals will only perceive a small percentage of mild pain, because primarily what the somatosensory cortex is doing is interpreting the quality of pain. The effects of long-term potentiation and chronic pain. We covered long-term potentiation quite a bit in neurotransmitters, so I'm going to just brief it here. The nociceptor axons, or I could say sensory axons that are attached to a nociceptor, pain receptor, release glutamate and substance P. The substance P will act as an agonist neuromodulator on NMDA receptors. Substance P prolongs the opening of these NMDA receptors, which will increase intracellular calcium, allowing more calcium to come in. And if you guys remember, when there's an increase in intracellular calcium, it'll bind with calmodulin, stimulate protein kinase, which will stimulate the receiving synapse, or we could say receiving dendrite, to increase the amount of AMPA receptors so that it can respond more quickly to subsequent stimuli, and it'll also allow the receiving a neuron to increase in size and number of synapses so that subsequent pain signals will be felt faster, stronger, and last longer. And that's long-term potentiation of chronic pain. The central nervous system analgesic system. Fibers from this system send serotonin-secreting neurons to the dorsal horn in the cord. Serotonin causes local neurons to secrete enkephalins. Enkephalins are a natural opiate that suppress pain. So as the enkephalins will suppress the pain signals, it affects both presynaptic and postsynaptic neurons of both type C and type A delta fibers. So it affects both slow pain and fast pain. It affects both the neo-spinothalamic pathway and the paleo-spinothalamic pathway. Morphine-like drugs can also mimic natural opiates such as enkephalins because they will act as agonists and work to suppress pain. What is referred pain? It is simply feeling pain in a part of the body that is remote from the tissue causing the pain. Causes of referred pain. First, let me draw your attention to the drawings on the right. They're representing the neuralization phase of development of the spinal cord in the brain. This is after the three primary germ layers have been formed. In this phase, you'll have somites that have developed on either side of the neurotube, and these somites differentiate into a sclerotome, myotome, and dermatome. The sclerotome are going to make the vertebra that go around the neural tube, and the myotome is muscles, and the dermatome is skin. So there's three different types of pain, and it's all related to their embryological association. Sclerotogenous pain arises from cartilage, bone, and other non-muscle connective tissue with the same sclerotomal origin. This example of this is someone who has knee pain, but it's being radiated from arthritis in the hip. Myotogenous pain arises typically from myofascial trigger points with the same myotomal origin. Example of that is lateral hand pain elicited with rotator cuff trigger points. Trigger points are basically muscle knots, and if you push on muscle knots directly over them, they often will refer some pain to a different area. That is their myotomal connection. Visceral pain arises from structures with shared embryological mesodermal innervation, specifically the intermediate lateral plate, because the medial plate makes the notochord. The example of this is right shoulder pain from polycystic liver disease. We're going to focus mostly on visceral pain in the remainder of this module. There are two visceral pain pathways. You have true visceral pain, which is the referred pain, and it travels in slow, unmyelinated C fibers. So it is the slow pain, travels in the paleo-spinothalamic pathway. It secretes both glutamate and substance P. And remember that the viscera have very dispersed pain fibers, so they have to submate before you'd actually really feel some discomfort or pain signals from them. The other is the parietal pathway. That is direct pain. Direct pain traveling in type A delta fibers. It is fast pain going through the neo-spinothalamic pathway. This pathway secretes only glutamate. It does not secrete substance P. What happens is when visceral damage, tissue damage, gets to the point that it starts to affect the serous membrane or even get so bad that it actually gets to the cutaneous region, but it will do it right along with the serous membrane, the visceral or parietal membrane, then it'll carry both the true visceral or the referred pathway, visceral pain, and the direct or parietal pathway. True visceral pathways is when pain is transmitted via pain sensory fibers within autonomic nerves. The sensations are referred to the surface area of the body, often far from the source. Parietal pain is conducted directly into the local spinal nerves. From the parietal peritoneum, pleural, pericardium, which have a high percentage of pain fibers, these sensations are usually located right over the source. So the parietal pathway, again, I wanted to say that it is fast pain and it is felt locally. You'll be able to pinpoint it because fast pain you can pinpoint. True visceral pain, again, is unmyelinated C fibers because it's slow pain. the palospinothalamic pathway, it is difficult to localize. Why? Because look at the image that I have up there, the top one, where it has a sensory neuron coming from skin, and then it has sensory neurons coming from the cardiac tissue. And it has them synapsing in the dorsal horn at the same place. Well, that's what's going on. Skin and muscle and viscera pain signals synapse in the cord at the same location with second order neurons. And that's why visceral pain can be perceived by skin. Example is angina, heart pain that's caused by intermittent occlusions of blood flow, and that'll cause left shoulder pain because of this common synapse in the dorsal horn. True visceral pain rarely elicits severe pain. It may just could be mild discomfort. Severe visceral pain is a result of a couple of things. Number one is ischemia. We've talked about ischemia before. That's where there's a decrease in blood flow. Or there's actual damage and chemicals have been released from the damaged tissue, so you have chemical tissue damage. Smooth muscle spasms. You have smooth muscle that go through all your intestines, and you have smooth muscle in all your blood vessels, but your intestines is really take up a large portion of your abdomen. And so if they have a spasm in there, you'll feel definitely feel some discomfort. And then you can have connective tissue distension, and where it's pushing on the connective tissue, and that's going to elicit some true visceral pain as well. It's frequently localized to two surface areas of the body at the same time because of the dual pathway. So here we have an example of appendicitis, where I have it at the lower right quadrant of the abdomen. I have a circle and it says pain. You see two neuron synapses there. Well, those receptors, there's some that are picking it up in the parietal pathway, and they are picking up where the serous membrane around the appendix is has some tissue damage. And then you have a synapses or pain receptors right over the organ itself, and that's going to carry pain all the way up a little higher to around T10, where you have the referred pain. Parietal pain happens when the disease of the viscera spreads enough to the surrounding serous membranes. So I already mentioned that it can be the peritoneum, the pleura, or pericardium, because they have a lot of free nerve endings. This pain is typically sharp, and it's directly over the irritated peritoneum, or we could say serous membrane. An example of that is appendicitis or pleurisy, or maybe cardiac tamponade. Now we're moving on to headaches. Headaches, some can result from pain stimuli within the cranium, and some result from pain stimuli outside of the cranium. So I have the example here. We got in the cranium on the left, and then the outside of the cranium. That is typically more as a result of muscle tightness and subluxation for the outside of the cranium. Headaches can be caused by so many things that I could fill up the remainder of the PowerPoint slides in this module just listing different things that headaches. So I just filled one slide and stopped. Headaches are caused by irritation of venous sinuses, damage or irritation to the tentorium, stretching of the dura mater at the base of the brain, inflammation of the meninges, muscle spasms, abnormal intracranial vasospasms, eye strain, dehydration, of course cervical subluxation, trauma to the meningeal blood vessels, crushing, stretching them, or the medial meningeal artery being damaged, which is the most sensitive, sprain, strain to the spinal column ligaments, sprain, strain to paraspinal cervical muscles, and that's just to name a few. So here in this diagram, I wanted to point out the tentorium, the falx cerebri, and the falx cerebelli. Mainly the tentorium and the falx cerebri, because these divide the area of, especially the tentorium, of the areas of the brain of certain types of referred pain for headaches. So referred headache pain is going to be based on that tentorium. Stimulation of pain receptors above the tentorium is going to refer pain to the front half of the head, or the cerebral cranial vault. Then the stimulus of pain receptors below the tentorium is going to refer pain at the posterior aspect of the head, and that's the brainstem and the cerebellar vault headaches. Stimulation of pain receptors inside mucous membranes of the nasal sinuses will refer pain to behind the eyes and the forehead and the scalp. And then you can have nasal sinuses or eye headaches. Face pain, not fast pain, but face pain, any kind of pain sensation you feel on your face, that's actually transmitted via the cranial nerve 5. So I'm going to get a little more detail about a few types of headaches. Meningeal headaches are a result from low cerebral spinal fluid, where the fluid drops to less than 20 milliliters. And most commonly, this is due to dehydration, just not getting enough water, or maybe drinking too much really high solute liquids. Or it can be caused from meningitis, which is caused by inflammation. Migraine headaches are a beast of their own. They are not a typical headache. They are completely different. It is not exactly known what causes a migraine, and all the physiology is not clear. So what I have here is just a summary of the consensus of major or primary cause of migraine headaches. So they result from abnormal vascular phenomena. This happens where some migraine headaches, they'll begin with a prodromal sensation, like an aura, where they either have visual disturbances, see flashing lights, or they have nausea, some kind of aura. They usually have, or very sensitive to sound. There's always something preceding the migraine headache. What happens then is you'll have vasospasms. The blood vessels will start to constrict, and that'll cause a sudden increase in blood pressure. And that constriction is going to cause some ischemia. So you're going to have decreased oxygen to the tissue beyond that. Now, blood is not like a stroke, because blood is getting through, but it's going to decrease oxygen a little bit. Well, after a while, the blood vessel itself is going to fatigue, and so then it'll just release its constriction and go into vasodilation. This sudden vasodilation will drop blood pressure real suddenly and cause that constant throbbing or pulsing pain. And you have this vicious cycle where it goes from vasospasm to vasodilation, vasospasm, vasodilation. So you have this throbbing, and your blood pressure is going up and down, and they're extremely nauseating and very, very painful headaches. Thermal sensation. We're now getting into temperature. Thermal graduations are determined by receptors. So the way the body tells how warm or how cold something is through thermal receptors. We have cold receptors in our skin, warmth receptors in our skin, and of course we have pain receptors, nociceptors. Cold and warmth receptors are located under the skin. There's typically 3 to 10 times as many cold receptors as there are warmth receptors. Warmth receptors are only identified by skin tests, where I guess in a clinic somebody said, is this warm? Is that warm? Do you feel that? Kind of a thing. They are not identified histologically, whereas cold receptors have actually been identified both with skin tests and on histology slides. Thermoreceptors versus nociceptors. Cold thermoreceptors will respond to cold sensation between 15 to 24 degrees Celsius, which translates to 59 to 75.2 degrees Fahrenheit. Warmth thermoreceptors will respond to warmth sensation between 30 to 49 degrees Celsius, which will translate to 86 or to 120.2 degrees Fahrenheit. Nociceptors respond to cold temperature, freezing cold temperature between -10 to 15 degrees Celsius, which will translate into 14 to 59 degrees Fahrenheit. And they respond to heat at 49 degrees Celsius or 120.2 degrees Fahrenheit. What the problem is some of these receptors is the skin will begin to burn at 44 degrees Celsius or 109 degrees 0.4 Fahrenheit. So your skin would already be burning before the nociceptors pick it up. Skin also freezes at -15 degrees Celsius or 5 degrees Fahrenheit. Anything below those temperatures or above those temperatures, you don't feel anything because the nociceptors have been destroyed. Transmission of thermal signals. Thermal signals travel parallel to pain signals. A peripheral nerve will send a thermal signal to the dorsal horn, and it will synapse with a second order neuron. It'll cross over via the anterior commissure, so desiccate. It'll travel up the cord in the spinal thalamic tract, and it'll send information to the reticular formation and the thalamus. So the spinal thalamic tract carries both thermal and pain signals. Now the module is switching topics to talk about sleep, brainwaves, and seizures. Brainwaves form a continuous current ranging from 0 to 200 millivolts. The frequency range of brainwaves is 1 to 50 plus hertz per second. The higher the frequency, the more active the brain is. Brainwaves are typically irregular on EEGs, but sometimes they have a pattern. Brainwaves are classified based on frequency. So listing them from the highest frequency to the lowest frequency is gamma, beta, alpha, theta, and delta. Gamma brainwaves have the highest frequency. Typically, they're greater than 30 hertz per second. They are synchronized waves and present when there is heightened perception, where someone maybe have very focused attention. The brain is extremely active. And these occur in the cerebral neocortex. Beta waves frequency are from 14 to 80 hertz per second. They are asynchronous waves recorded in the parietal and frontal lobes. They indicate the brain is busy. It's busy completing mental tasks, concentrating, or thinking. They also occur during REM sleep. They are involved with memory. Particularly during REM sleep, these beta waves help the brain process what it studied or learned through the day and record it as memory. Alpha waves have a frequency of 8 to 13 hertz per second. They are synchronous waves with a voltage of about 50 millivolts. They are part of restful, resting state. That means you're awake, but your eyes are closed. And not closed on purpose. It means that it's when you're first drifting off to sleep or when your body is slowly waking up. They disappear completely during sleep, and they are recorded mostly in the occipital region. Alpha waves have burst appearance during sleep called sleep spindles. This results from spontaneous feedback in the diffuse thalamocortical system and possibly the reticular activating system. Theta waves frequency is 4 to 7 hertz per second. They're considered slow waves. They are synchronous and recorded in the parietal and temporal regions. They occur during light sleep with sometimes intermittent sleep spindles, which, if you remember, those are the alpha waves. They're also seen during daydreaming or meditation, but sometimes they're seen in adults with emotional stress, especially with disappointment and frustration. And there are also many brain disorders and degenerative brain diseases that are associated with theta wave performance. Delta waves, my favorite wave. The frequency is low, 3.5 hertz per second. It is the slowest synchronous wave. They have a high voltage that can range from 20 to 200 millivolts. This wave is seen during deep sleep, but it's also seen throughout in the infant stage or in serious brain disease. The thalamus is not stimulating the cortex in any way, shape, or form when delta waves are present. Electroencephalograms, also known as EEGs, are the instruments that can record these brain waves. Sleep versus coma. What's the difference? Well, in the state of sleep, you're unconscious, but you can be awakened. In a state of a coma, you are unconscious, but you cannot be awakened by sensory or any other kind of stimuli. Sleep is an active inhibitory process. It sounds like an oxymoron, but you have to actively be asleep. There's several stages, but we're going to just talk mostly about the two main distinct stages, which are slow wave, and they have strong low frequency brain waves, and REM or REM, which stands for rapid eye movement. And as I mentioned before, that's going to show beta waves. Slow wave sleep consists of low frequency brain waves. It begins with theta waves that progress into the delta waves. This accounts for most of the time sleeping. It can lead to deep, restful sleep, especially when you get into the delta waves. In this phase, you will decrease vascular tone, blood pressure, respiration, basal metabolic rate. You can dream during this phase, but you typically don't remember it. And this is also the phase if you sleepwalk. Rapid eye movement sleep, or REM sleep. This is paradoxical sleep, or desynchronized sleep. This occurs every 90 minutes for about 5 to 30 minutes throughout your time sleeping. And of course, all sleep studies, they use 8 hours as the number or the parameter. So I know you students don't get 8 hours of sleep every night, but just bear with me for just the explanation. During this phase, eyes undergo rapid movement. That's how it got its name. This phase, you can have active, vivid dreaming, and these dreams can be recalled. You'll also experience body movements, and some people may even talk during their sleep during this phase. During REM sleep, the brain is highly active. It can increase as much as 20%. Brainwaves similar to wakefulness brainwaves, such as beta waves, are seen during REM sleep. REM sleep has a role in learning and memory. The brain will consolidate and process information during the day, during REM sleep, and then store it into long-term memory. So not getting enough sleep does affect your memory. It's not understood why REM breaks up slow wave sleep, why there's cycling of every 90 minutes going into REM sleep and then going back into slow wave, but it happens. And it may have something to do with the reticular activating system. The reticular activating system keeps the cortex alert. It is responsible for consciousness and enhances excitability. It filters sensory input. It allows you to filter out those house noises that you have so you can get a good night's sleep. It regulates the skeletal and visceral muscle activity, and it's inhibited by hypothalamic sleep centers. The reticular formation is a cluster of neurons running through the white matter of the brainstem. Now we're specifically going to talk about the raphe nuclei. What is the role of the raphe nuclei? It communicates with the hypothalamus. It plays a role in the circadian rhythm of sleep, and it releases serotonin. The serotonin released by the raphe nuclei is converted into melatonin by the pineal gland. Melatonin causes drowsiness. Therefore, sleep is dependent on serotonin. Basically, what the pineal gland does is it constantly makes melatonin. That's its job, and it needs to be inhibited. It does not need to be stimulated to make melatonin. It needs to be inhibited to stop making it. So melatonin synthesis and secretion is influenced by light. Increased production during the dark period of the day because there's nothing inhibiting it. Light will stimulate the optic nerve, which will then stimulate the hypothalamus suprachiasmatic nucleus, and that will send a signal to inhibit melatonin synthesis in the pineal gland. There's 4 stages of sleep. The first stage is light sleep, where you have the theta waves that are broken up by intermittent alpha waves, which are sleep spindles. Then stages 2 and 3, the theta wave frequency becomes slower and slower until finally it reaches about 1 to 3 waves per second. Stage 4 is delta waves, where it's the slowest wave, and that is where you get your deepest, most restful sleep. So, a brainwave summary. The more active the brain, the higher the frequency of brain waves. 2 brain waves are associated with full wakefulness. That's beta and gamma. Beta, brain is busy. Gamma, brain is geared up. Game on. 3 brain waves are associated with sleep. Includes the process of going to sleep and waking up. Alpha, theta, delta. Alpha is like, I'm going to sleep, or I'm starting to wake up without my alarm clock. Theta, that's it, I'm drifting off. And then delta is deep sleep. Epilepsy and brain waves. Epilepsy is caused by disruption of normal balance between inhibitory and excitatory transmission in one or more brain regions. It's typically too much excitatory stimulation. The brain is either having too much glutamate and or not enough GABA. When discharge frequency rises above several hundred cycles per second, synchronous waves begin to spread over the adjacent cortical regions. These waves may gradually recruit adjacent areas of the cortex and then lead to an epileptic seizure. Epileptic seizures can be seen on EEG machines, and they are used to diagnose this condition. Seizure classification. There are 2 main groups of seizures classifications. You've got general and partial. General seizures affect both sides of the brain simultaneously. There's 2 types of general seizures. There's grand mal, which is also known as tonic-clonic, and petit mal, also known as absence seizures. Then the partial or focal seizures will arise from one local area of the brain, one hemisphere. Now, this type can spread to the entire brain and lead to a general seizure, but they'll always start just in one hemisphere. These are 2 types. They're known as simple or Jacksonian, and the other is complex, also known as psychomotor, also known as temporal lobe, because it only occurs in the temporal lobe. Seizure symptoms. Grand mal seizures have 2 stages followed by a post-ictal stage. The tonic phase, which you'll see in the diagram depicted in A and B, is where you have a general contraction of the entire body, just the whole body goes stiff. And it lasts for about 10 to 30 seconds and the person is unconscious. Then they go into the clonic phase, and where the body is rapidly jerking. They're having a seizure then, and that'll last for 30 to 60 seconds. This is followed by what's called a post-ictal phase. That's depicted in the D image, and that's where the seizure is over and the person is physically tired, confused, and may have a headache. I do have a video that shows an individual having a seizure. I think it's pretty good demonstration of what actually happens during the grand mal seizure, and I want to encourage you all to watch that. Petit mal seizures are also known as absence attacks. That's where the person loses consciousness for about 5 to 10 seconds. It typically affects children. They look like they're just staring into space. Sometimes they're accused of just having attention deficit disorder or just not paying attention. They will stare into space, but their eyes may be blinking, mouth might be twitching. but they are totally unaware of what's going on. The other two seizures that we talked about, the simple Jacksonian seizures, this seizure, the person seldom loses consciousness, and they'll experience some interesting sensations like tingling in their extremities, or they'll have a visual aura, typically with lights. They may hear ringing in the ears, tinnitus. They may have facial grimacing. It can affect the autonomic nervous system, so they may be sweating. The other type is complex psychomotor seizures, or also known as temporal lobar. And the EKG on this specific type of seizure will only show activity in the temporal lobe. These individuals will also have a prodromal where they'll have a visual, auditory, and olfactory hallucination. This isn't auditory where they just hear ringing in the ear. They'll hear specific music, bells, a specific sound that they can name, not just ringing. Or they will smell something and they can identify it. The diagram shows a skunk, but it doesn't have to be something nasty. They can smell roses, you know. They will have an impairment of their consciousness. They won't be able to respond. They often can be seen picking at their clothing, difficulty swallowing their saliva while they're experiencing the seizure. I'm not going to detail of the seizures, so this is all you need to know from this module.